Want to go ahead and get started. Welcome everyone and Happy New Year. Nice to see all of you again. Welcome to the January edition of Pain Research Working Group. Today we're going to have Dr. Lisham Ashrafioun, and he's going to speak about addressing upstream and downstream suicide risk among veterans with chronic pain. But I do want to make a small announcement prior to getting started with that and introducing our speaker today. I just wanted to make folks aware of a recently released RFA by NCCIH. This is a renewal and additional funding of the Pain Management Collaboratory Pragmatic and Implementation Trials. So this was recently released in December. If you are on the CORE's mailing list, you will have gotten an email about this RFA with a link to the RFA and also a link to an informational cyber seminar that we're sponsoring. It's going to occur on January 10th at noon Eastern. And so at this cyber seminar, we will have Dr. Peter Murray, who's a representative of NCCIH, and Dr. Robert Kearns, who's one of the PIs of the Pain Management Collaboratory. And they'll be giving a brief overview of the RFA. And we'll also have some representatives from our partners. So from PMOP, Dr. Friedhelm Sandbrink and Dr. Jen Murphy will be attending. And from OP, Office of Patient-Centered Care and Cultural Transformation, we'll have Dr. Ben Fligler. And the partners will be there to talk a little bit about their priorities for funding and with information about how and when to contact them if you're interested in applying. So I would encourage you, if you have any interest, to consider attending. This cyber seminar will be recorded, but I'm not entirely certain when that will be up and available. And so if you are interested in a link or more information and you didn't get it through the CORE website or email list, please send me a message in the chat and I'll make sure you get that information. Okay, so after that announcement, let's get on to the business for today. So today, our presenter is, as I mentioned, Dr. Lisham Ashrafioun. He is a research investigator at the Center of Excellence for Suicide Prevention at VA Finger Lakes Healthcare System and an assistant professor of psychiatry at the University of Rochester. He completed his internship at VA Ann Arbor and completed the VA Advanced Fellowship Program in 2016 at the Center of Excellence. He's published over 60 articles, mostly focused on at least some combination of substance use, chronic pain, and suicide. While his work focuses mostly on intervention development to address novel therapeutic targets among individuals with substance use disorder and/or chronic pain, he also utilizes the COE's resources and expertise in VHA administrative and suicide surveillance data to further understand suicide risk among these veterans. He's recently received funding from NIDA, NCCIH, and HSR&D to address some of these therapeutic targets, such as perceived social isolation among veterans and civilians, and also to increase non-pharmacological pain treatment seeking among veterans seeking prescribed opioids. So with that, I'm going to turn it over to Dr. Ashrafioun. Thank you for joining us today, and I'm very interested to hear your talk.
Great, thank you so much. And I'm extremely excited to present here. As they say it on the radio, I'm sort of a long-time listener, first-time caller. So I'm Lisham Ashrafioun, clinical psychologist at the COE and at the University of Rochester. And I'm going to talk about some of my work on characterizing and addressing suicide risk among individuals with chronic pain. I wasn't sure about sort of the best way to present here. So this is I'm basically going to throw a bunch of information at everyone about the work that I've been doing since coming to the center. But first will be a quick overview on the literature of pain and suicide. Then I'll talk a little bit about my contributions to the literature on characterizing suicide risk among individuals with pain from work that I've done with VHA administrative and suicide surveillance data, and also from national survey data. And then this will sort of lead me into more recent work that are projects that we're currently looking to get ramped up. And I view these projects as sort of addressing suicide risk across the suicide risk spectrum. So this is my lengthy list of collaborators and research team members, grants, disclosures, what have you. Essentially, we find that pain is associated with increased risk of suicide. So there was a meta-analysis on 31 studies that found that people with pain were more likely to report lifetime and recent death wishes, suicidal ideation, suicide planning, suicide attempts, and suicides. This meta-analysis also found that current and lifetime suicidal ideation were reported in 9% and 21% of patients with pain, respectively. And then some of our work has highlighted how common suicidal ideation is among veterans experiencing pain. So, for example, we looked at a sample of over 17,000 veterans who screened positive for primary care mental health, and 53% reported at least thoughts about death, and 34% reported at least thoughts of killing themselves. Ilgen and colleagues identified veterans with specific pain conditions and found that several of these, including back pain, psychogenic pain, and migraines, were associated with suicide after accounting for key demographic and clinical characteristics. In an analysis we completed, we compared over 30,000 veterans with a recent suicide attempt to 30,000 veterans with no suicide attempt who were matched on factors like age, sex, mental health treatment utilization. And we found that those with pain conditions were more likely to have a suicide attempt, again, after controlling for psychiatric disorders, medical comorbidities, and demographics. And then I also just want to present some data from the VA's behavioral health autopsy program. So this program was implemented in 2012 by Central Office, and it's completed in correspondence with our center. And it's a pretty comprehensive evaluation that brings together veteran suicides reported to providers and SPCs. And it includes standardized chart reviews, interviews of friends and family members of veteran suicide decedents, and there's a review of care completed by SPCs. And so in over 2,800 chart reviews, over 50% had a 50% of veteran suicide decedents had a pain diagnosis documented in their medical record, which was the most common risk factor identified. And so this sort of highlights how common pain conditions are in general, and specifically among veterans with suicide decedents. And I just want to note as well that a sizable proportion of these individuals were also having issues with medication misuse. And so there was also interviews done on the behalf of 404 veteran suicide decedents, and we found that over 69% indicated that the veteran had been experiencing some kind of pain. And again, often this was accompanied with use of pain medications. There was often medical problems and mobility issues as well. So among patients with pain, what are some of the risk factors of suicides that we see? And just an important thing to kind of keep in mind, a lot of this research is actually based on cross-sectional data, and more longitudinal studies are needed to better understand the causal and temporal relationships between suicidality and pain. But nonetheless, I just want to highlight some of the findings in the literature. So, for example, pain catastrophizing has been found to be associated with suicidal ideation and intentional overdose. Insomnia is associated with suicide attempts and suicidal ideation. So we had a recent paper that was published that found that veterans with moderate to severe pain and also insomnia were more likely to attempt suicide than those with moderate to severe pain with no insomnia, and also those with insomnia but no to mild pain. And as I mentioned previously, there's that large study examining specific pain conditions, finding pain, back pain, migraines, and psychogenic pain were associated with dying by suicide after accounting for more some of those robust risk factors of suicide. Studies have found that feeling like they're a burden on others and that others would be better off without them, on having distress in interpersonal relationships are associated with suicidal ideation after adjusting for key covariates. Other factors such as wanting to escape from pain or helplessness and hopelessness also appear to be associated with suicide-related factors among patients experiencing pain. And then research on suicide outcomes and pain severity is sort of a little bit more mixed. So there's some studies that indicate that it's associated with suicidal ideation, but not after accounting for depression. Others have found that there's no difference in pain intensity when comparing those who have had a suicide attempt to those who have not had a suicide attempt. But again, these are based off of cross-sectional studies. There was one retrospective cohort study by Ilgen and colleagues that found that moderate and severe pain was associated with suicide deaths. And so I was also interested in looking into this further. This association of pain intensity and suicide outcomes. And so we looked at the association of pain intensity and suicide attempts among a cohort of veterans utilizing specialty pain services. And when we think of specialty pain services in the context of the step care model of pain, it's when you have sort of a higher level of psychiatric and medical complexity and more intense treatments are needed than what might be effective in lower levels of care like primary care. Therefore, this transition into specialty pain services might represent a time at which there's higher levels of risk of suicide. And so I was interested in assessing the extent to which mean pain intensity levels in the year leading up to the index visit, so the initiation of services, was associated with suicide attempts in the year following the index visit. And I was also interested in conducting subgroup analyses of those with no attempt in that time prior to initiation of services, and those with an attempt prior to those initiation of services, so that we could look at to see if pain intensity was associated with one's first attempt and also reattempt respectively. And so we looked at all veterans who initiated these services from 2012 to 2014. We used the VA corporate data warehouse to obtain demographic, diagnostic, suicide attempts, treatment utilization, and medication data. That data was linked with data from the VA Suicide Prevention Application Network database, also known as SPAN. This contains data on all suicide attempts reported by SPCs. So essentially, we used both suicide attempts that were identified using both administrative data sets and also, administrative data sets from SPAN and also administrative data sets from CDW and then also from SPAN. And so there was 200,000 veterans who were identified. And ultimately, we found that they had pretty high rates of psychiatric disorders, not surprisingly. So 45% of depression, over a quarter had PTSD, over a fifth had other anxiety disorders. Most of the cohort had back pain, so about 86%, over 2/3 had arthritis. And in terms of medical conditions, over a quarter had diabetes, over half had hypertension. And at this time, we're talking 2012, 2014, about 60% had filled an opioid prescription in the year prior to initiating services. And when we look at the rate per 100,000 person years, we found that severe pain was nearly 1,500 per 100,000 person years, compared to not even 500 per 100,000 person years in the note of mild pain group. But I do want to point out, though, that even this, 562 is still pretty high, which, sort of says, maybe says something about the cohort and the high level of comorbidity within it. When we look at the analyses adjusting for these, robust risk factors of suicide that I have noted here, we find that, of course, the effect is attenuated, but it's still significantly associated with greater risk of suicide attempt for both veterans experiencing moderate and also veterans experiencing severe pain. In the first subgroup analyses of only those with no suicide attempt, so moderate and severe pain was associated with, the veteran's first suicide attempt following the index visit in the adjusted analyses. Similarly, moderate and severe pain were associated with a reattempt. So they had a previous attempt prior to the initiation of services, and then they had a reattempt following it. So importantly, I just want to point out in terms of this reattempt group that, or the reattempt analyses, that only pain intensity and alcohol use disorders were actually predictive of reattempt. So other mental health conditions like PTSD, depression, and other covariates were not. But pain, severe and moderate pain were. So basically, this was sort of a comprehensive assessment of suicide attempt risk data among veterans experiencing pain. We found that higher pain intensity was associated with greater risk of suicide attempt following the initiation of specialty pain services. And then pain intensity was also predictive of one's first attempt and reattempt. I think it highlights not only the importance of addressing pain in the context of suicide prevention, but it also sheds light on the timing and setting for suicide prevention. And so, as I noted in my previous slide, initiation of specialty pain services represents a point at which some patients are not responding to other less intense treatments, and they have a higher level of psychiatric and medical complexity. So a referral to this setting, especially with those who have a high pain intensity, may sort of set off a red flag. So some limitations include that sort of, the billing code that we use, stop code 420. We sort of know that the billing code is used for pain services, but it's kind of broad. It may be defined differently from site to site. So the suicide attempts rely on clinician input either to the medical record or into the reporting system for SPAN. And of course, we know that, SPCs and other clinicians are extremely busy. And for the medical record input, that's not always, the diagnostic code for suicide attempt is not always included as a specific diagnostic code. And then, of course, we were also unable to capture other, potentially important pain-related factors that would have been useful to consider, like pain catastrophizing and pain interference. And we were also interested in looking at the data from this cohort a little bit more, and given the level of comorbidity in it, we are interested in opioid use disorders and comorbid psychiatric disorders. And we were wondering if veterans with comorbidities conferred additional risk and therefore may need further attention. And so we assessed the additive risk of opioid use disorders and 5 psychiatric disorders. So again, we're looking at risk above and beyond each of the individual conditions. Essentially, like rare rates is the relative excess risk due to interaction. We want our confidence interval to be above 0. And we found that veterans with OUD and depression and veterans with OUD and alcohol use disorders were at higher risk of suicide attempt after accounting for key covariates, including the individual disorders. So there was a 7% increase in risk due to the comorbidity of depression and 23% for AUD relative to any of them alone. The AP represents the attributable proportion due to interaction, and 29% of the people in this 29% of the people who attempt suicide with comorbid OUD and alcohol use disorder is attributable to the additive interaction of the two disorders. So basically, we found that OUD and depression and OUD and AUD confer additive risk above the contribution of each of the individual conditions, highlighting the importance of addressing comorbidities to mitigate suicide risk. So you think of maybe like medications like naltrexone, it might be a potential solution given its ability to treat both AUD and OUD. Buprenorphine, of course, is the gold standard treatment for OUD. It reduces all-cause mortality, may provide some pain relief. Given that this analysis was completed in veterans who are being seen for pain care, non-pharmacological options that address both pain and other mental health problems may be of use. So, for example, cognitive behavioral therapy for pain and substance use disorder patients, or mindfulness-based interventions have the potential to address underlying transdiagnostic risk factors that affect a variety of conditions. Now, we've also done some work with national survey data looking at prescription opioid misuse and suicidal thoughts and behaviors. So the National Survey of Drug Use and Health recently started assessing reasons for prescription misuse. Reasons for prescription opioid use. And they do this to inform the assessment of substance use and treatment needs. And so I thought this was a good opportunity to see if these reasons are associated with suicidality as a way to potentially inform suicide prevention strategies as well. So previous research, which actually mostly was done in large surveys of adolescents, found that people misusing prescription opioids for its intended purpose, so pain management, they're misusing, but they're at least doing it to manage their pain, had a similar, less severe clinical profile of substance use compared to those who reporting using prescription opioids as prescribed by the doctor. So this would be, they found similar rates of cannabis use, heavy drinking episodes, etc. And this substance use profile was significantly less severe relative to those who were misusing prescription opioids for non-intended purposes, or even for a mixture of intended and non-intended purposes. So what about these, kind of subtypes of prescription opioid misuse and suicide variables? So we pooled data from the 2015 through 2017 NISDA data set, and it included over 45,000 adults reporting any prescription opioid use in the last year. Respondents are asked yes/no questions regarding if they had seriously thought about trying to kill themselves, so suicidal ideation. They made any plans to kill themselves, so suicide planning, and if they tried to kill themselves, so suicide attempt. And this is asked for the past 12 months. And then we also include in the analyses covariates like depression, alcohol use disorders, drug use disorders, overall health rating, demographics. And respondents are provided with a comprehensive list of prescription opioids, and they're asked which, if any, they had used in the past 12 months. The data set then provided a recoded variable that differentiates those who had used prescription opioids appropriately or those who misused them. And misuse was defined as taking a prescription opioid in a way that was inconsistent with how a doctor directed them to take it. So that would be like using without a prescription, using greater amounts, using more often or longer than was directed. And then respondents who indicated that they had misused prescription opioids were subsequently asked to report the reasons for their misuse. And so these reasons included to relieve pain, for sleep, to relax, to deal with emotions, to get high. This is my favorite one, because they were hooked, to experiment, to combine effects with other drugs, and then for other reasons. And then we divided respondents up by misuse subtypes. So there was no misuse, misuse for pain only, that is, for its intended purpose, other reason only, that is for a non-intended purpose, and then a mixed subtype where there was both intended and non-intended purposes reported. So overall, misuse was reported in 12.3% of individuals who had used prescription opioids. And, not surprisingly, pain was overwhelmingly the most common reason for misuse, with nearly 3/4 of the sample. And then, relaxation, getting high, to help with sleep, to help deal with emotions, rounded off the top 5. And this breaks down the reasons for misuse by each of the subtypes. So the pain-only subtype, of course, was at 100% pain with no other reasons. The other reasons only subtype was 0% for pain with a range of percentages across the other reasons. And those with those in the mixed subtype all had pain, and they also had endorsed at least one other reason. So the percentages reporting suicidal ideation, planning, and attempt by reasons for misuse subtype are presented here. And we compared all the misuse subtypes to the no misuse subtype group as the reference group. And we see that after accounting for key, these clinical and demographic covariates, that suicidal ideation is higher among each of the 3 subtypes compared to those using opioids as prescribed. Now, although it's not pictured here, SI was higher among those using for mixed reasons compared to the pain-only subgroup. Similarly, for the suicide planning, it's higher among each of the 3 subtypes compared to those using opioids as prescribed. And as shown with suicidal ideation, planning was higher among the mixed subtype relative to the pain-only subtype. We didn't find any differences between the other reason subtype and the pain-only subtype for any of the 3 suicide-related variables. And then for attempts, just the mixed reason subtype and the other reason subtype was associated. Again, no differences between any of the misuse subtypes and the pain-only subtype. And so this study provides some additional nuance regarding prescription opioid misuse and suicide-related variables. So we found that prescription opioid misuse across the subtypes is associated with suicidal ideation, planning, and attempts. But there's a greater proportion of the mixed subtypes that have a history of ideation and planning relative to the pain-only subtype. So again, combining pain management with other evidence-based treatments may be useful in mitigating suicide risk. So again, like combining behavioral treatments for insomnia with cognitive behavioral therapy for chronic pain might be helpful in tackling people who are misusing for mixed reasons, like to deal with sleep and to deal with their pain. Okay, so to shift gears, with these studies in mind, I wanted to discuss some of the ways that we've thought about addressing the issue of pain and suicide risk. And so there's kind of a variety of ways, of course, in which the VA does this, such as some of the opioid safety measures, use of storm and reach vet, increasing suicide screening across settings, and I'm going to primarily focus on the work that I'm more directly involved with. And so there's multiple ways that suicide risk could be addressed across the spectrum of interventions, from more upstream approaches to more downstream approaches. And first, I'll talk a little bit about just sort of addressing pain regardless of level of suicide risk. So we know that pain is independently associated with suicide, so you expect that addressing pain should reduce the overall risk of suicide. So consistent with this, there's been a study that's found that several non-pharmacological pain treatments are associated with reduced risk. So there was a study that identified Army service members with chronic pain after deployment between 2008 and 2014. And they looked to see if participating in acupuncture, chiropractic care, exercise, cold laser therapy, and other non-medication approaches were associated with various adverse outcomes, including developing a substance use disorder, accidental poisoning, suicidal ideation, and suicide attempts. And so they compared soldiers who had used these approaches to those that hadn't, and they found that those using these non-pharmacological approaches, it was inversely associated with each of the adverse outcomes, so including suicidal ideation and self-inflicted injuries. There was also a single group observational study of civilian patients with pain enrolled in a cognitive behavioral oriented interdisciplinary rehabilitation program that indicated that suicidal ideation decreased in nearly half of the patients reporting ideation at baseline. And also, I'm working with several others in central office in Durham on a manuscript that's looking at the CBT for chronic pain national training data. And it's looking like veterans who are receiving this treatment are not only do they have significantly reduced pain interference and depression, but also suicidal ideation over the course of treatment. So, sort of exciting findings, and sort of be on the lookout for this manuscript soon, hopefully. Okay, so related to addressing pain is to increase treatment seeking to non-pharmacological pain treatments among veterans with chronic pain, regardless of their actual suicide risk. So this is a little bit more of maybe like an indicated prevention, in that they have some risk in terms of maybe having functional impairment and they're using prescription opioids, but they may or may not have, like, at high level of suicide risk. So I wanted to talk a little bit about an HSR&D merit that we're getting started on right now. So just a little background, at the HSR&D state-of-the-art conference on non-pharmacological pain treatments, the psychosocial intervention group sort of agreed that CBT, ACT, and MBSR have strong efficacy and effectiveness, and that research should really kind of focus on barriers of engaging in these types of treatment, because ultimately they tend to be underutilized and may even sort of suffer from issues with adherence. Of course, the VA has made some really great advances in addressing some of the logistical barriers. And so, these treatments, there's enhanced availability of them, accessibility, but just sort of another sort of critical barrier that should be addressed are intrapersonal factors. So beliefs can also serve as a potent barrier of engaging in psychosocial and other non-pharmacological pain treatments among veterans with chronic pain, particularly among those who are being prescribed opioids. So what might some of these beliefs be? So some might be stigma related. So people think I'm crazy. They could be related to their experience of pain. I'm never going to get any better. It could be related to opioids. Opioids are the only thing that helps. Or if I, do this type of treatment, they're going to take my opioids away from me. Could be about the actual psychosocial treatment. So people won't think my pain is real. It's all in my head. And then it could also be about, a person's confidence in their ability. So I can't function no matter what I do. And so basically, there's this rigid thinking, automatic negative thoughts that are kind of related to a variety of things like pain catastrophizing, fear of movement, stigma, that may be getting in the way of trying other treatments out. So we're looking to utilize CBT for treatment seeking, which was developed by my co-I, Tracy Stecker. And ultimately, it's a one-session telehealth delivered intervention that targets at least 3 beliefs that are interfering with treatment engagement. She has tested this intervention among individuals with AUD, veterans with PTSD, veterans reporting suicidal ideation, and pretty much across the board, she's found that participants receiving CBT-TS are 2 to 3 times more likely to attend treatment compared to education control conditions. Now, I just want to highlight that these studies were all done in people who have never received any mental health treatment. So in addition to this, she's found that among those who've initiated treatment, the people who received CBT-TS are more, they attend more sessions of treatment as well. And she's also found some more downstream effects on actual clinical outcomes. So, reduced depression, PTSD symptoms, reduced suicidal ideation in these studies. And so we thought that veterans with chronic pain on opioids who are resistant or hesitant to try psychosocial and other non-pharmacological pain treatments would sort of be a great target for this intervention. So essentially, CBT-TS seems to work on addressing beliefs that are acting as barriers through very cognitive-based approach of cognitive restructuring. And so the focus of our intervention is largely going to be on addressing barriers to psychosocial interventions. So we expect the largest effects to be there. But we also think that there may be effects on other non-pharm pain treatments and potentially other treatments like mental health or substance use disorder treatment as well. It is a patient-centered approach. And so if people are thinking about chiropractic care or initiating medications for opioid use disorder or something like that, we will go with that and work with them on that. And so essentially, through greater engagement in these treatments, we expect there to be downstream effects on clinical outcomes, which would, might be something like decreased opioid use, pain interference, mental health symptoms, among others. So aims 1 and 2 will be to look at treatment engagement. Do they initiate treatment, and are they more likely to be retained? Aim 3 is more of the distal effects. So, okay, we think that they'll engage in these treatments, so we'd expect their symptoms to improve over the course of the follow-ups. And then, as I mentioned, the focus of the study will be to look at psychosocial treatment. So our exploratory aim is to look at other non-pharmacological pain treatment engagement. So we'll be recruiting 300 veterans with chronic pain that's contributing to functional impairment, and the veteran is on at least 20 morphine equivalent daily dose and has a 90-day supply. Participants won't have any recent engagement in non-pharmacological pain treatment, and they'll score at least a 4 on each of the items of the PEG. We'll be recruiting veterans nationally through queries of VHA administrative data, and participants will receive either CBT-TS or pain education control condition, which just sort of presents pain treatment options. And all aspects of the study will be completed by phone. Assessments are done at baseline, 1 month, 3 month, and 6 months post-treatment. And we'll be assessing treatment and treatment initiation and retention through data queries and chart reviews. The retention will be measured as the number of sessions completed. We'll be assessing beliefs, including like hope or optimism, beliefs about opioids, beliefs about other types of treatment, pain catastrophizing, pain self-efficacy, fear of movement. And then our clinical outcomes include pain interference, opioid misuse, opioid dose, physical functioning, anxiety, depression, recent suicidality. So the study is currently being reviewed by IRB. We're in the just-in-time process for this. And so ultimately, we're hoping to get things going in early spring 2022. So where the last approach I discussed is to get people into treatment that may help them, this would more directly intervene on suicide risk factors, again, regardless of whether the veteran is endorsing suicidal thoughts or not. And so for this, we focus more on loneliness and social isolation. So I'm currently working on a NIDA R21 that's looking to address clinically significant loneliness in individuals with opioid use disorders using cognitive behavioral therapy for loneliness. We've adapted and refined this from a Swedish and online version. Unfortunately, I'm extremely fluent in Swedish, and I was able to translate it. No, I'm just kidding. Google Translate's awesome, and was able to do enough where we could make sense of what was actually happening in the treatment. So, although the trial's ongoing and all the focus is more broadly on opioid use disorders, most of our sample is actually comprised of individuals with chronic pain who are misusing or addicted to opioids. We've also been working on a cousin grant of this that focuses specifically on veterans with chronic pain, regardless of their opioid use status. That will be resubmitted to our R&D in March after a very promising initial submission. But basically, loneliness is highly prevalent among individuals with chronic pain, and pain is predictive of the onset of loneliness. And these high prevalence rates are not just sort of among older adults, but younger adults with chronic pain experience high rates of loneliness. And they often over-identify with, they often identify being more withdrawn, isolated, and having fewer friends relative to peers without chronic pain. And among patients with pain, loneliness is associated with lower life satisfaction, higher depression, high pain-related interference, less mobility, lower ability to complete activities of daily living. Social isolation is predictive of future pain interference. And patients with pain who isolate also tend to over-identify with their pain. They have lower levels of activity and they take more sick leave. So it sort of leaves like a real fertile ground for increased suicide risk. A bit more downstream would be to target both pain and other risk factors among a sample that they're overall they're sort of more at risk, like those who have comorbid mental health problems. So this is maybe more of a selective prevention strategy. And so one way that we've approached this is through addressing chronic pain and insomnia among veterans with comorbid psychiatric disorders and or who are reporting suicidal ideation. So, we know that pain and sleep are important reasons for why people are misusing opioids. These reasons are associated with faster suicidality, and pain and comorbid insomnia increased risk of suicide. And so we did this project in collaboration with VA Office of Mental Health and Suicide Prevention, the MyRec in Little Rock, CIH in Buffalo, and with a researcher at the Durham VA. and it involves web-based CBT for insomnia with face-to-face CBT for chronic pain in veterans at risk of suicide with insomnia and chronic pain. Just some results on a very small N here, but there seems to be some promising results. So we see reductions in pain catastrophizing, pain interference overall, depression, insomnia severity, of course. And then we also see reductions in self-defeating thoughts in the majority of people as well. And although not pictured here, we found that suicidal ideation severity was reduced in 60% of the participants reporting ideation at baseline. So we're sort of excited about these findings. This is a potential way for somebody not to necessarily like formally deliver CBTI, but to facilitate the veteran's self-administration of it. So combining it with a face-to-face, or I guess in these days would be a screen-to-screen intervention, can help with accountability of completing this while they're also completing, in this case, brief CBT for chronic pain. So finally, more downstream is where we would more directly intervene on suicide risk. So it's important to be able to address chronic pain and suicide risk together. So addressing suicide risk and chronic pain within the same intervention is consistent with the national strategy for preventing veteran suicide's goal to incorporate suicide prevention components into treatment and for conditions that share risk factors with suicide. And also the National Suicide Prevention Alliance, they recommend that treatments address specific conditions. They actually specifically cite pain as a way to mitigate suicide risk. Now, while pain management strategies alone may partially mitigate suicide risk, as I discussed earlier, meta-analyses found that there's more robust treatment effects when suicide risk is explicitly targeted in treatment. So direct interventions on suicide risk have larger effects on suicide-related outcomes at post-treatment and follow-up compared to indirect interventions. Also, in general, people who are suicidal are, sometimes excluded from trials, even though they may be sort of most in need of treatment. Suicide prevention efforts that don't explicitly focus on pain management, on the flip side of this, it may neglect key risk factors associated with suicidality, like the avoidance of activities because of pain catastrophizing. And so an intervention that combines suicide risk mitigation and pain management strategies, we think will be sort of the most effective and efficient way of addressing both suicide risk and functional impairment and chronic pain. And overall, it's just sort of more efficient to address these together rather than maybe doing them sequentially. So mindfulness meditation-based interventions may serve as a solid candidate to address chronic pain and suicide risk. So of course, the core features of these interventions emphasize the practice of awareness through purposeful, non-judgmental attention to experiences. MMBIs like mindfulness-based stress reduction and MBCT, they have broad support across medical and psychiatric conditions. They address several underlying mechanisms characteristic of depression, anxiety, PTSD, drug craving, chronic pain. There's also growing evidence that these treatments reduce the intensity of pain and unpleasantness of pain through changing the appraisal of painful sensations, decreasing attentional fixation on and hypervigilance for pain-related stimuli, decreasing emotional reactivity to pain, increasing positive affect, decreasing thinking or behavioral patterns that maintain impairment and suicide risk. So ultimately increasing an individual's ability to disengage from repetitive negative thinking patterns, increasing emotional awareness, decreasing emotional reactivity, and reducing emotional and behavioral avoidance. Now, MBCT relative to MBSR places a greater emphasis on understanding how cognitive, emotional, and behavioral experiences contribute to the development and maintenance of problematic thinking and behavioral patterns. And so, we thought that this makes MBCT ideally suited to address both pain and suicide risk. And also, so research on MBCT for pain shows that it decreases depression and functional impairment in patients with fibromyalgia, decreases the frequency of headaches, pain interference, and pain catastrophizing, while also increasing self-efficacy. Among a sample of patients with a range of conditions, the researchers found that it maintained decreased pain interference and pain catastrophizing through a 6-month follow-up. For suicide risk, researchers have looked at the impact of MBCT for depression on suicidal ideation as a secondary outcome, and they found that SI decreased over the course of treatment relative to controls. More recently, there's been researchers from the New Jersey healthcare system, VA New Jersey healthcare system, that developed MBCT for suicide, which highlights elements of suicide prevention, like incorporating safety planning, emphasizing suicidal cognitions, and increasing awareness of warning signs of suicide in the treatment. And they found that patients reported significant reductions in suicidal ideation, attempts, depression, cognitive reactivity, rumination, hopelessness. And so this is I think we're in the final steps of getting this funded. It's a NCCI HR 34. It helps support an early phase mind-body approach for suicide risk and chronic pain. And it essentially provides data that will be critical for the planning of a subsequent full-scale efficacy trial. So aim 1 will be to integrate and adapt existing MBCT intervention protocols to address the unique needs of veterans who are at risk of suicide with functional impairment. And so essentially we'll sort of start with MBCT manuals for pain and suicide and incorporate factors that will be effective in addressing both. We will be looking at the feasibility and acceptability of MBCT for suicide and pain in an education control condition through a small randomized clinical trial of 76 veterans. So we'll be assessing things like treatment satisfaction and acceptability, participant flow through recruitment, from recruitment through follow-up by condition, participant adherence, therapist fidelity, things like that. And then we'll, sort of descriptively look at suicide risk outcomes like ideation and attempts, interpersonal needs, depression, and then pain outcomes like pain interference, quality of life, pain self-efficacy, catastrophizing. So I'm running low on time here. So I just spit out a ton of information. I may have blacked out at some points of the during the talk, with just some quick take homes. So suicide-related outcomes occur relatively frequently among veterans with chronic pain. There are several pain-related suicide risk factors that can be addressed. And to me, sort of the overall theme here is that addressing disengagement is critical. So chronic pain can sort of shrink the lives of people who are living with it. They're not doing things they used to enjoy. They're not taking care of themselves. They may be less active. They may be prone to isolate or withdraw from people. And our approach is, to basically expand their lives through engagement. And this might be through, through the healthcare system, by getting them engaged in evidence-based treatments, by intervening on their thoughts that are acting as barriers. It might be through increasing their engagement in meaningful activities through an approach like pain and or suicide-focused psychosocial interventions, or it could be through increasing meaningful social interactions through CBT preventiveness. And so that about wraps it up. And I'm sorry I don't have more data on these projects. I just gave a talk on the early career opioid pain core meeting that it took me over 5 years of submitting and getting rejected on grants to finally hit on one. Now I've hit on several. So I hope that this is just sort of a teaser presentation for one that I can give in a few years that will have more data for all these. Thanks.
Thank you. Thank you, Lisham. This was a great presentation, very informative. I loved hearing about all the work that you have. In that, I really appreciated your focus on two areas that I think are in particular need of that focus, and that is really thinking about how do we increase uptake and engagement in treatment. Since we have many treatments that we know are effective, but we don't have the engagement that we would like. I think that's really important. And then also focusing on veterans who have these co-occurring conditions, who, as you mentioned, are often excluded from our trials and sometimes have a harder time getting involved in treatment. So I think that's really wonderful. And we do just have a couple minutes for questions. I noticed that Brenda Fenton had put a question in earlier when you were discussing some of your work, looking at the relationship between pain intensity and suicidal outcomes, suicidality, ideation. So if Dr. Fenton's still on, maybe she could state her question.
Yeah, it was a really specific one, Alicia. Thank you. It was, what are the measures that you're using? Are you using one pain score? Are you using an average pain score in the 6 months before the suicide attempt? Just knowing that there's a lot of pain intensity information and how to best use it to measure risk, really.
Yeah, yeah. So in that analyses that I presented on, it was the mean pain score across the year prior to the index visit, and it was essentially an average of their pain scores. We started to look at, their pattern of pain intensity over the course of the year prior, but that analysis just kind of fizzled out just because of, not because of interest or anything like that, but the person working on it ended up leaving the center, and we haven't picked it back up again. We have looked at pain intensity trajectories though, but not in a pain specific cohort. So we ended up finding that that seemed to be kind of the main limitation of that data, that they weren't pain patients, because ultimately we did a latent class analysis, and we found that there were 3 classes to this pain intensity trajectories. Actually,
It's okay, Lisham. I know that we're just at time. I'll follow up with you if you don't mind, because we struggled with this with the musculoskeletal disorders cohort because of the inconsistency of reporting of pain of something that's supposed to be chronic, and the idea of treated and untreated pain severity. And one would think that untreated pain would have a much stronger association with suicide as compared to sufficiently treated pain, I guess. So if someone is low, we don't know if that, are you factoring in the treatment to say the reason that their pain is low is because the treatment is sufficient, not that the condition is not a very painful condition. So disentangling that treated and untreated is another thing that we're very interested in for suicide risk.
Yeah, no, that's certainly fascinating. We do have some of their, we have things like their mental health treatment utilization in this data set, and also non-opioid medications and complementary and integrative health treatment utilization that we might be able to look at that in this data set too, even. But the sort of the pain intensity scores during that time are kind of all over the place too. There's like a mean of 7, and it's not that everyone's getting their pain intensity scores taken at the exact same time. So it's another kind of limitation of the data too, is that just sort of a smattering of when pain intensity actually showed up in their medical record too.
Yeah, having a flashback there. The ones with more pain have more measures, right? So you have a more reliable measure. So definitely interested, and we'll be following your talks coming up to see what you guys are uncovering. So thank you.
Thank you, Brenda. It's always good to commiserate and discuss the challenges of VA data. So thank you, everyone. Wonderful presentation, and I look forward to seeing you all next month at February's edition of Pain Research Working Group. Bye.
Thanks, everyone. Thanks, Alicia.
Thank
you, everyone.